العلم يحلو كلما كررته، ولذاك عدت مكررا لحلاوته، وبكثرة التكرار يكثر نفعه، وبكثرة التكرار يكثر نفعه، فادأب لتعلم من فوائد حكمته.
Any questions? Everything is clear? Okay. Okay, thank you.
Thank you, Dr. Allen. MSc and RCPCH, Assistant Consultant Neonatology in the National Guard Hospital. You are welcome.
Thank you very much. Assalamu alaikum. I'm very happy to be today with you here in Egypt. Actually, this is my first lecture in Egypt for the last 5 years. I hope it will be a nice lecture. My voice is not like Dr. Alaa. There is no mic. I will try to be high voice. Anyway, I'm happy to be with you today in Egypt. This is my first lecture here for the last 5 years. Now we are going to be the continuation of Dr. Alaa lecture. He gives a pathophysiology of respiratory failure. Now we are going to manage his patients. His patients are in failure, and we are trying to use the nasal ventilation mode of respiratory failure. So by looking into this picture, what do you think, what is this mode of ventilation we are using for this baby? Nasal CPAP. Or nowadays we call it nasal respiratory support. It's not only just nasal CPAP, because we can use nasal CPAP or we can use a nasal IPPV, nasal intermittent positive pressure ventilation. We give CPAP with rate. So as we know nowadays, it is a fact that any advanced unit, there is a good correlation between the advances in neonatology and advances in the management of respiratory failure. And we have a lot of modality to treat patients with respiratory failure. We can start from CPAP to patient trigger ventilation to high frequency ventilation. What is the aim of management of Dr. Alaa patient who was in respiratory failure? The aim of management is to improve the survival of such patient. But at the same time, we don't want this patient to go into complication of our management. We want a patient who survive but without problems. So now as we mentioned, we have a lot of modality. We have high frequency ventilation, we have patient trigger ventilation, we are using volume targeted ventilation. But in spite of this, we have a new problem which started to appear, which is bronchopulmonary dysplasia or BPD. So what is the effect of BPD on the patient survival? If you have a baby who already passed the acute phase, you ventilated him well, he passed, he survived, but he developed BPD. What problem you expect this patient to come back with to your unit? Anybody know? Sorry? Yeah, such patient will have two main problems. They will come back with respiratory problems like respiratory infection, hyperactive airway disease, and a repeated admission to the hospital from this problem. The other problem is that this patient, studies have shown that patients with BPD, they will have higher incidence of developmental delay. So you ventilated the patient, you pass the acute stage, but still he has a problem. So we are trying to look to modes which can improve the survival, but at the same time decrease the incidence of these side effects.
Stunted growth.
Sorry?
Stunted growth.
Stunted growth.
Stunted growth. Yes, this will be part from his chronic problem, repeated infection, increased metabolic rate, so it will be a part of his problem. As we mentioned, they will have this problem. Another thing, the CP patient, and one of the study has shown that Patient with extremely low birth weight, if we ventilated them, for each additional 10 days of ventilation, they will have increased odd ratio of 1.2 of CP. So this patient was ventilated well. The problem is they develop BBD. We are, as usual, for extreme low birth weight, we are doing early head ultrasound and late head ultrasound. So this patient does not have IVH, does not have other problem, but studies have shown that prolonged ventilation itself can increase the incidence of CP in the patient. So what is the nasal respiratory support? As we mentioned, we are changing from not only nasal CPAP, we are using the nasal respiratory support, or calling it sometimes minimal ventilation or gentle ventilation. This is a non-invasive method for maintaining functional residual capacity. As Dr. Alaء mentioned, the idea of giving CPAP is to maintain the functional residual capacity. If you have seen in the previous lecture, the pressure volume loop, if you maintain the functional residual capacity, you will need less work to maintain the lung open. But if the lung go down PEEP of 0, you need a strong or more hard work to reopen this alveoli again, and this is going to increase the work of breathing. Nasal respiratory support will include two parts, which is a nasal CPAP and nasal ventilation, or nasal SIMV, or nasal intermittent post-pressure ventilation. What is the CPAP? From the name, CPAP. Anybody can translate the letter CPAP? Continuous positive airway pressure. Continuous means what? Continuous means we are applying this pressure throughout the whole cycle. It is there during the inspiration and during the expiration. Positive airway pressure, we are applying a pressure to the airway. What is the importance of this pressure is to keep the alveoli distended. So this pressure, we apply it to the airway, it goes through the airway down to the alveoli to keep it open, so it will not be collapsed. So as we mentioned, with the next cycle of respiration, we don't need a high work to open it again. And of course, we cannot use this one in apneic patients. If you have a patient who is completely apneic, you cannot use CPAP. So it is a continuous positive airway pressure and should be used in a spontaneously breathing baby. It can be used to treat obstructive apnea. And sometimes it will help in the central apnea, but if your patient is completely apneic, you cannot apply CPAP. What is the effect of CPAP when you apply it to the patient, the baby who came in respiratory distress with increased work of breathing, with increased oxygen requirement, and you apply to him CPAP? What's the effect you expect to have from this CPAP? First one is splints the chest, airway, and pharynx. If we splinting the upper airway, what will happen? What's the benefit of splinting the upper airway and lower airway? Okay, splinting the upper airway, if you have this will help in management of patient with obstructive apnea. Because patient with obstructive apnea, usually they obstruct the upper airway, then start to go into central apnea, or we call it mixed apnea. Splinting the upper airway will keep the upper airway open. If you have a wide open airway and another one, and you are pushing air through, which one is the tidal volume will be higher, which will reach the lung? The one with the narrow airway or the one with the wide airway? The one with the wide airway. So when we keep this airway widely open and we are giving the same pressure, this means more tidal volume is going down to the alveoli to keep it open and to keep the functional residual capacity. Splinting the chest wall. The preterm baby, especially the extremely low birth weight baby, the compliance of the chest wall is higher than the compliance of the alveoli. So when he starts to have breathing, what will happen to the chest wall? It will move inward. So instead of moving outward, because there is high compliance and the alveoli is not opening, the chest wall will move inward. So by splinting the chest wall, this will help to decrease the work of breathing. The baby will not work hard while he is on CPAP. So we mentioned decrease total airway resistance, enhance and maintain functional reserve capacity, and by maintaining functional reserve capacity will prevent the alveolar atelectasis and what we call atelectotrauma, because the alveoli will not be collapsed. If you reopen again, this shearing process itself, it will release the inflammatory mediator, which will precipitate later on in the BBD. Regularize breathing pattern. How the CPAP will regularize the breathing of the baby? By applying the CPAP, we mentioned first, it will decrease the work of breathing. There is no inward movement. At the same time, we are giving higher tidal volume. Minute ventilation equal what? Rate times tidal volume. So when the patient have a low tidal volume because he's getting a small amount of air, he will be breathing fast to compensate for this small tidal volume. Now you open the airway and you are pushing more air, maintaining the functional capacity, giving higher tidal volume. This will help to decrease the respiratory rate. Improve in surfactant metabolism. By keeping the alveoli open will help the recirculation of the surfactant, enhancement of the secretion and the recirculation. If this alveoli is atelectatic with the release of protein and proteinaceous material, this is going to inactivate the surfactant. And as we mentioned, reduce work of breathing, as we mentioned why, splinting the chest wall and decrease the respiratory rate. So the result of this will result in reopening of the collapsed and unstable alveoli, increase surface area for gas exchange, preserve surfactant, especially if applied early, increase the mean airway pressure and prevent intrapulmonary shunting. And Dr. Alai explained it, how to prevent intrapulmonary shunting, because you open the alveoli, you improve the ventilation perfusion matching. So the net result of this, you are going to improve both the oxygenation and the ventilation. The use of CPAP, it's not something new. The CPAP have been used since 1971. And the use of CPAP over the last decade has been increased 4 times. So the CPAP is not something new, but the benefits, or people start to be aware of the benefit of the CPAP recently. But the CPAP has actually been used since about 40 years now, if you calculate. What are the indications for CPAP? We have many indications. Any patient with increasing work of breathing at the time of delivery, it's mainly used for maintaining lung expansion in condition in which the alveoli tend to collapse or to fill with fluid. Collapse like RDS patients or meconium aspiration syndrome. Some are collapsed and some overinflated, or post-extubation. Fill with fluid, very famous scenario is a patient with transient tachypnea of the newborn. And a lot of things, transient tachypnea, pulmonary edema, heart failure, high chest wall compliance, like extreme low birth weight baby, post-operative, pulmonary hemorrhage, pneumonia. Do we have other indication for CPAP apart from respiratory distress? Apnea. We mentioned apnea, especially for the obstructive apnea. Do you have other indication to keep the airway open? Some baby who are sometimes have stridor and laryngomalacia and bronchomalacia. Laryngomalacia, trachomalacia or bronchomalacia, it will work by the same mechanism, splinting the upper airway. Do we have a contraindication for use of CPAP? The contraindication is that when you have a definite indication for ventilation. This is a contraindication for CPAP. Like upper airway anomaly, patient with guanal atresia, how are you going to apply the CPAP? Patient with cleft lip and palate, and you are applying CPAP and he is losing the CPAP. You cannot maintain the CPAP. Patient with tracheoesophageal fistula. Patient with cardiovascular instability and impending arrest, and he is on inotropic support and he is critically ill. Unstable respiratory drive. As we mentioned, patients who are completely apneic, apnea of prematurity, you start to treat it with methylxanthine and patient is not responding and he is still apneic. You cannot apply the CPAP. Untreated congenital diaphragmatic hernia. When such patient should be intubated from birth immediately. You cannot apply anything about that. Or when the CPAP is failing, you start the CPAP and CPAP is not working well and CPAP is failing, you need to shift to other mode of ventilation. How to deliver the CPAP? We'll look to this picture. How to deliver CPAP to the baby? We can look. We have 3 components here. This is the circuit from the source of the airflow. This is the circuit will go from here to the baby. So this circuit should have a warm, humidified air. You cannot apply dry air or cold air. It should be warm and humidified to maintain the temperature of the baby and to help in losing the secretions. And we have the source for the pressure from here, either the flow. The pressure will be generated either you have infant flow CPAP here by the flow. This one will be generated after the baby, like the bubble CPAP. And we have the interface between the CPAP and the patient. This is a nasotracheal tube, this is a face mask, and this is the nasal prong. So we have 3 components: the circuit, the generator of the CPAP, and the interface between the baby and the CPAP. The pressure of the CPAP, how much pressure you need. We mentioned the CPAP, the pressure will depend on the underlying pathology you are treating. If you are just treating upper airway problem, patient has good lung, low FiO2, you are just treating upper airway like laryngomalacia or, sorry, I think I speak about other slide. This is the CPAP pressure, how we control the CPAP pressure. We may either change in the amount of gas flow into the lung. You have infant flow CPAP, you increase the flow, you increase the pressure, or you increase the obstruction, which is after the baby, like the bubble CPAP. You push the tube lower down in the bottle, you have higher pressure. And these are the CPAP pressure generator. It can be a ventilator CPAP, can be flow driver CPAP, it can be bubble CPAP. These are the generator of the pressure. The interface between the baby and the CPAP, as we mentioned, we have a lot of things. We have single nasal bronch, binasal bronch, short and long, nasopharyngeal, endotracheal tube. Endotracheal, it's not an ETT CPAP, but it will be used through the nose. Nobody using any more ETT CPAP. It will through the endotracheal tube to the trachea, but it will be through the nose only. Head box with nasal seal, nasal cannula, or face mask. These are different type of nasal CPAP. We have Argyle, Hudson. Actually, in our hospital, we are using this kind, Hudson CPAP. Which one better to use? To use a single bronch or binasal CPAP? Binasal. Why we should use the binasal, not only a single bronch CPAP? Sorry?
Like the nature.
Sorry? No, not like the nature. Yeah, why you like the nature? What's the benefit from doing like the nature? Dr. Alaq mentioned the resistance. What about the resistance? It will be with short binasal CPAP. This will have the lowest resistance. With the lowest resistance, you will have low resistance. You will have high flow and better tidal volume. And the study have shown that meta-analysis of randomized trial shows that the short binasal bronch, when compared with single bronch nasopharyngeal CPAP, more effective at preventing re-intubation. If you are extubating a patient from a ventilator to CPAP, they have better oxygenation and better respiratory rate. So we should use short binasal bronch. Another study here also confirms that Hudson bronch and the infant flow driver has the least resistance. You can hear the infant flow driver and the Hudson. They have the least resistance when you apply it. So as we mentioned, lower resistance will be more tidal volume transmitted to the baby. How much CPAP should be applied? This depends on the pathophysiology. What is the indication of the CPAP? If we are treating just upper airway problem, apnea of prematurity, laryngomalacia, trichomalacia, patient need only low FiO2, we can use a pressure from 4 to 5. But if we have seen the patient with this problem, severe RDS, actually usually we start from 6, even not from 5. You start from 6 and you can adjust according to the response. You can go, I wrote 5 to 8, but in some cases you can even go up to 10, depending on the response of your baby. How to care of the baby on CPAP? Now patient brought to the unit, we connect him to nasal CPAP. How are we going to care about this patient? This involves vigilance in monitoring the infant condition and maintaining optimal airway, maintaining a patent CPAP, and preventing the complication. Now you have a baby, you brought him to the unit, you connect to the CPAP, the baby is in front of you. What are you going to monitor in such patients? Oxygenation, heart rate, color of the skin. You need to monitor respiratory rate. You need to monitor, is this patient responding to your CPAP? Is he improving or deteriorating? How you know? You are monitoring the saturation, the FiO2 requirement. This patient is still working hard or improving, the grunting is still there or improving, heart rate and blood pressure. What could happen from the CPAP to affect the heart rate and the blood pressure? What will happen if you are applying higher CPAP? How it will affect the circulation? If you apply high pressure and the lung is overinflated, there will be increased intrathoracic pressure, decreased venous return, decreased cardiac output, hypotension and tachycardia. And at the same time you affect the circulation of the brain. Now you have decreased blood flow from the brain.
Decreased cerebral outflow.
Yeah. So this is what we are going to monitor: respiratory rate, work of breathing, saturation, cardiovascular status, GI. It is very famous, the CPAP will affect the GI in which way? Distension. What you call this one? CPAP belly. It's very famous complication. Neurological status, to see if his patient is improving. If he's deteriorating and high CO2, low oxygenation, patient can will be hypoactive, affecting his neurological status. And thermoregulation, as we mentioned, the air which should go to the baby should be warm and humidified to control his temperature. Okay, how frequent shall we do suction for patient on CPAP? There is no frequency. It should be individualized, depend on the need of the patient. If the patient is stable and CPAP, if I2 stable, patient is not working hard, saturation is improving, if I2 is going down, you don't need to do regular suction. But at the same way, if the patient is not deteriorating suddenly, most commonly maybe has airway obstruction, either the position or the secretion. So this should be individualized depending on the condition of the baby. Before we are doing suction, we need to moisten the nares with normal saline or sterile water just to lubricate the catheter, to loosen the secretion and to avoid the trauma from the catheter. As we mentioned about the humidification, maintain adequate humidification of the circuit, adjust setting to maintain gas humidification at or close to 100%, and the humidifier temperature should be set to 36.8 to 37.3 to give a warm humidified air. Position, which position you should put the baby? Should put him in his supine, side lying or prone position?
Supine position, elevation of the shoulders.
Actually, the best position is the prone position for the baby while in CPAP. If when you put him, you are ventilating the bases of the lung, and at the same time it's easier to control his upper airway. But the main problem sometimes, if you have a patient, you just admitted, you put UVC and UEC, and the nurses, they cannot take care of the lines while the patient was lying in prone position. So you need to put him supine or side lying. If you put him supine or side lying, you need to take care of the neck position. You put a roll under the head just to make it a little bit extended. And this is, you can see, this is a prone position, how we are putting the baby. Complication, a lot of complication can happen. Pneumothorax or PIE, it is more in the acute phase and it is not a contraindication. If you have just small pneumothorax, you can continue with that. If you do not need to put a needle or a tube. Nasal obstruction, we said we'll do suction depending on the condition of the patient, not regular. Nasal septal erosion or necrosis, we'll go more detail. Gastric distension, this is a common complication.
NG decompression.
We want to put the patients, after some time the nurse will tell you that the abdominal gas will start to increase. So how can we help in preventing that?
NG decompression.
And we've got a good size OGT tube. Either we do intermittent suction, this is better to do intermittent, not a continuous suction, to deflate the abdomen. But this is not a contraindication for feeding. Does the CPAP cause neck? Does the CPAP cause necrotizing enterocolitis? No, studies have shown that. One of the studies they have done and they adjusted the other factor, CPAP does not cause neck. It can cause feeding intolerance, but it does not cause neck. And feeding intolerance as a common complication. And this is a classic X-ray of the CPAP belly. That if you do X-ray, a lot of gases inside the abdomen, just this need intermittent suction. Sometimes you need to get a good size tube, size 8. Because for small babies they bought size 6, but if you change to CPAP, you need to put a good size orogastric tube for deflation of the abdomen. How to prevent the complication? This is one of the worst complications, to have erosion of the nasal septum. So how to try preventing this complication? Evaluate the nasal septum regularly. We need to use the correct size. Sorry?
Lubricants?
No, it's not recommended to put any lubricant on the septum. Just use the correct bronch. Secure bronch in place correctly. Use the Velcro mustache. This is the one. You can see the one under the bridge. This is the Velcro mustache. There will be a duoderm under on the lip, and this one will be fixed above. Once you put this bridge, it will be fixed here. So it will not be easier to be twisted in any direction. Use the Velcro mustache, secure bronch in place. Use the correct size bronch. Don't use a bigger one which will compress on the septum. And don't use a small one because you will lose the CPAP at the same time if you use a small one. Maintain a distance. You can see this bridge here, this one. You should keep a distance between the septum and this one about 2 to 3 millimeters. Avoid twisting of the bronch. When you reposition the baby from one position to the other, you should take care that there is no twist of the bronch. It's not compressing on the septum. Don't use cream, gels, ointment or adhesive barriers on the septum. Use the duoderm on the lip but not directly on the septum. Type. How I know now I put the patient on the CPAP? How I know if this patient CPAP is helping or not helping? patient came, then this, respiratory status. If he was tachypneic, he start to improve. Saturation start to stabilize. If I2 requirement start to improve. Sometimes if you have CO2 high in the blood gas and lung gases, and his gas start to stabilize, his blood pressure is stable, his heart rate is okay. This means the patient is improving on the CPAP. These are the signs: reduction of grunting, reduction in degree of sternal and intercostal recession, and the other things which we mentioned. CPAP failure. Before it was one. What are the criteria? Actually, there is no consensus about the criteria. What's the exact criteria of CPAP failure? And that's why we are saying when we use any mode of mechanical ventilation, use science and arts. Not only there is no fixed guideline to say this patient is now just failing on CPAP. Before they are using the degree of distress, but it appeared to be something subjective, so it was not used anymore. We are depending on the objective criteria. Some books you can see the reference they wrote FI2 more than 60% even. But now I think it's better to go down to some studies, recent study are using more than 40%, because if you keep patient on high FiO2, you are wasting the time for surfactant. That's why they went down to about 40%. If patient is more than that, you can give in and out surfactant, the ensure technique. So this is one of the criteria of CPAP failure. More than FiO2, more than 40% on CPAP, and saturation we cannot maintain between 85 to 92. And these are the recommended saturation now for the extreme low burst weight baby. Before it was 92 to 95. Now recommendation down to 85 to 92 is accepted. Respiratory acidosis defined as PCO2 is more than 65 and the pH is less than 7.2. Dr. Alaء mentioned the criteria of respiratory failure, but we mentioned also for the extreme low burst weight. Usually are accepting we write in our order sheet, accepted blood gas pH 7.25, PCO2 45 to 55 or 45 to 60 even. Frequent or severe apnea. If this patient, you are putting him in CPAP and his frequent apnea. If we have one bad apnea, more than one in any 24 hours which need bagging, this patient is in failure. You cannot keep in CPAP. Or if he has more than 12 in 6 hours requiring other intervention about from bagging, you just increase FiO2, he responds. You just stimulate, he responds. So we can tolerate more desaturation and apnea as long as we don't need bagging. But if the patient needs more than one time bagging, this is failure and you need to ventilate the patient. Respiratory failure, the infant is not. What could be the cause? If this patient, we put him on CPAP and patient is not improving or he is in failure, what could be the reason why the patient is failing with CPAP?
Severe cases.
First of all, the severe cases and your CPAP is not sufficient to treat the underlying pathology. So the patient maybe need ventilation, needs surfactant, and as we mentioned, we can give in and out surfactant in short technique. What other reasons? Okay. Obstruction. You have a problem, the CPAP, you put him for 6 hours, he was stable, and suddenly his FiO2 requirement is going up. Maybe the upper airway position is not okay, or he needs to be suctioned. Okay, but you put a patient 2 days on CPAP, and suddenly he started to deteriorate on CPAP at 48 hours of age. Pneumothorax is not a common. Other reasons? Patient start to develop other pathology. Patient start to develop patent ductus arteriosus. Sometimes, if he develops patent ductus arteriosus, he will start to deteriorate. If patient develops sepsis, this is common cases. PDA common the second or third day. 1 week of age, patient is stable, then start to be hypoactive, deteriorating, and abdomen distended, not tolerating the feeds. These all are signs of sepsis. Sepsis could be a reason, and you need to treat the sepsis. Apnea of prematurity, it could be a reason, and first you need to treat with methylxanthine before you shift to mechanical ventilation. These are the causes which we mentioned. If it's not receiving effective CPAP, CPAP is not sufficient to treat the infant condition, and underlying condition is contributing, like apnea of prematurity, sepsis, or PDA. So if your patient is failing on CPAP, first you need to evaluate that there is no problem with the upper airway, no need for secretion, CPAP is functioning well. If you did all of this, your CPAP is 6, maybe you can increase to 7, increase to 8. And you need to treat the underlying condition if he has a PDA, if he has sepsis. When to wean from CPAP? Also, I think there is not a lot of consensus. So each unit has different ideas. About the weight, I could not find any clear weight when to wean from CPAP. People are saying if patient was ventilated and you extubate, after 72 hours you need to think about removing from CPAP. But patient which are already from CPAP from the start, If he is stable in room air, saturation more than 90%, patient has no evidence of tachypnea or retraction, and have minimal to no apnea or bradycardia, you can start weaning the CPAP. Okay, your baby now is on CPAP of 7. What is the best way to wean this patient from CPAP? Anybody knows how many ways we have to wean from CPAP?
7.
Yeah. Decrease the pressure. Down to
5.
no, from 7 to 5. You should not jump by 2.
Slowly.
Yes, slowly. So this is one way.
7, 6.
7, 6, 5. This is one way of weaning from CPAP by decreasing the pressure. Anybody knows other ways?
1 hour on, 1 hour off.
Yeah, we have off CPAP time. So your patient, you are putting him continuous at 24 hours. You cannot start 1 hour and 1 hour. You start 1 hour and 4 hours, then 2 hours and 5 hours, like that. You can increase the time of CPAP gradually. But which way is the best? Which one is better? As we mentioned, we have 2 methods: reducing the pressure, the one you mentioned, go down gradually, and reducing the time, cycle of 1 hour off, 2 hour on, and increase the time off progressively. But the study have shown that reducing the pressure is better, not the time off and time on, because every time you remove the CPAP completely, you can lose the CPAP. So we cannot remove it completely, then you reapply to reopen the lung, and this can cause shearing process. So in randomized trial, weaning by pressure was shown to be associated with significantly greater weaning success in infant born at 23 to 31. So the better way is the gradual weaning by pressure, not by time. When to put him in CPAP again? If he didn't do well, if you remove him from CPAP, start to desaturate, if I2 requirement is going high, have severe or bad apnea, you can just, or retraction.
And energy.
Sorry?
Clinically and energy. There is CO2 retention again.
We can retain, but I mentioned now we can accept higher CO2 up to 60. Clinical is better too. Yeah. If patient is deteriorating, either clinically, blood gas will be a later thing, but early clinical assessment will be better for reintroducing the CPAP. Okay, now what about the weaning from CPAP, from mechanical? We mentioned we use him either for treatment or for weaning. So is there a difference between weaning from ventilator to room air and weaning from ventilator to CPAP? This is Cochrane database 2003. The cumulative data from trials suggests that infant extubated to nasal CPAP from mechanical ventilation to CPAP has less apneas and bradycardias, less acidosis, less oxygen requirement, and less need for intubation. Number need to treat is only 5. Anybody know what does it mean? Number need to treat is only 5. This is studies mainly for the babies who are less than 1,250 grams. Number need to treat is 5. This means if you extubated 5 patients from mechanical ventilation to CPAP, you will prevent 1 case of respiratory failure or failure of extubation. For each 5 case, you will prevent 1 case of failure of extubation. So it found that it's better to extubate the low birth weight baby less than 1,250 grams from the ventilator to CPAP, then you can wean from CPAP. We'll go to one of this coin study. This is one of the biggest study done recently in multi-center study, which is a CPAP or intubation. Now we want to decrease, as we mentioned, we want to decrease the complication BBD, and before studies have shown that, earlier study showed that the center who has higher use of CPAP, they have a lower incidence of BBD. So they did multi-center study.
That one?
Sorry?
I think one can have a study.
About that.
No, this is training.
The coin study, this is CPAP or intubation multi-center study. There was 610 infants. The gestation age between 25 to 28 weeks plus 6 days. They want to compare the use of CPAP and intubation. And the outcome of the study, the primary outcome was the rate of death or BBD. Actually, they randomized the patient at 5 minutes of age. Why they choose 5 minutes of age? They did not start it from 0, because the babies who are from the start, they need intubation, intubated already. Baby who from the start looks fine and needs CPAP, they put in CPAP. They choose 5 minutes of age. They choose the baby who are borderline CPAP and ventilation by assessment. They want to compare the difference or the effect of CPAP and ventilation, and the primary outcome was the rate of death or BBD. So the result was that early nasal CPAP did not significantly reduce the rate of death or BBD as compared with intubation. And even though the CPAP group, they use higher PEEP. They start by PEEP of 8. This was the reason they have a higher incidence of pneumothorax. And the group of CPAP, they have incidence of pneumothorax about 9%. And the ventilation group, they have incidence of 3%. But it was found that there was a fewer infants who received oxygen at 28 days, and they had, of course, fewer days of ventilation. So by definition, BBD should be defined at age of 36 weeks. So at 28 days, they have less oxygen requirement. But when they wait until 36 completed gestational age, there was no difference. So there was no difference in the rate or BBD. There was no significant difference. There was a little difference, but it's not statistically significant. So the overall conclusion of this big study was that the early nasal CPAP was not detrimental to preterm infant. It was not harmful to try CPAP with these patients. But it did not give a big significant difference in decreasing the rate of death or BBD. Another big study was the support study, surfactant, positive pressure, pulse oximeter, a randomized trial. They did nearly the same, and this was published after the first one. They went by the gestational age a little bit down to 24 to 27, from 25 to 28. And again, CPAP initiated in the delivery room compared with intubation and surfactant, and the primary outcome was nearly the same, death or bronchopulmonary. But this was a different multi-center study also. Result was this, or BBD did not differ significantly between the CPAP group and the surfactant group, but there was some significant. What was the significant? There was less frequently required intubation and less requirement for postnatal corticosteroid for BBD. You know, sometimes people use corticosteroid for treatment of BBD, so there was less need for corticosteroid to treat BBD patients on the CPAP group. They required fewer days of ventilation and were more likely to be alive and free from oxygen and mechanical ventilation by day 7. So the author concluded what? The result of this study supports the consideration of CPAP as an alternative to intubation and surfactant. So it is still a consideration, but it did not prove that the CPAP alone can decrease BBD and death. So this was nearly in controversy of the earlier study. The explanation was that the BBD is a multifactorial. It's not only application of CPAP. And these people also, they believe in early extubation. So they did not keep the patient on higher ventilation. So once the patient is stable, they extubated him earlier. So now if we found from this study there is no big difference between the CPAP and ventilation in the element of BBD and early death. So if we want to give the surfactant for such a patient, actually now there is some study ongoing to give surfactant by nebulization to avoid ventilation completely, but it's not approved as a drug till now. So what is the best way if you want to give surfactant and avoid ventilation? To use the ensure technique. So if you think your patient, he will need surfactant, give surfactant but try to extubate early. Ensure technique, which is intubation, surfactant and extubation to nasal CPAP or nasal IMV even. So early surfactant replacement therapy with extubation to CPAP compared with later selective. The surfactant can be prophylactic, can be early selective and late selective. Anybody knows what is the hours difference? Prophylactic, early selective, late selective. Prophylactic should be given within 15 to 30 minutes. Early selective from 30 minutes to 2 hours. This is the early selective. After 2 hours, this is the late selective. So study shows that early surfactant replacement therapy with extubation to CPAP compared with later selective we mentioned after 2 hours, replacement and continued ventilation with extubation from low ventilator. The patient who are given surfactant and extubated, they have less need for mechanical ventilation, they have lower incidence of BBD, and at the same time they have fewer incidence of air leak syndrome. So if you think your patient still needs surfactant, you can give in and out, intubation, surfactant and extubation. Success of CPAP. To have a successful CPAP, we do have many factors. First, the gestation. Dr. Hani Ali and co-worker reported that a chance of successful keeping a patient on CPAP depends on gestational age. So patients who are less than 24% gestation, they found that only it was successful in 10% of the cases. But when they went up By 25 weeks of gestation, the success rate has been increased to 45%. One other factor is the experience of the center. The more you use the CPAP, the more expert you will be and the more successful rate you will have. Because patient on CPAP, which patient will need more care? The one on CPAP or one on ventilation? One on? No, the one who needs less care is the one on CPAP. The ventilation needs less care. It's easier to manage patient on ventilator. If you want to do a blood gas, nursing care, it's easier for the nurses to manage patient on the ventilator. But it's more difficult on CPAP because if she want to take a blood, patient is awake, you cannot sedate him, he start to move in the CPAP. If she start to move the CPAP, you need to refix. So this needs some experience in the center. If you use the CPAP more, you become more expert, you will have a more success rate on CPAP. Now we finish the nasal CPAP, we'll move to the other part of the nasal respiratory support, which is the nasal intermittent mandatory ventilation or nasal SIMV, or sometimes called nasal intermittent positive pressure ventilation. What do you expect from giving a rate with CPAP? What benefit you expect from giving a rate with a CPAP? What is if you have a patient failing with CPAP and you want to try him CPAP with rate? I don't know if you are using here or not, but what benefit you expect? What other thing we are adding to the CPAP now? We are adding a rate. What the rate will do? The same like the ventilation. You are going to augment the CPAP. Patients failing or just giving a continuous flow positive pressure. Now you are to give him some breath, extra breath. You can put a rate of 20 or 25, rate of 30, who is going to receive a breath. What this breath is going to do to the lung? It's going to recruit the alveoli. You have some alveoli which already you bought a CPAP, you are trying to recruit, still some is not recruited. You are giving a PIP, more main airway pressure, to open this alveoli. So you are going to augment the CPAP and you are going to recruit the CPAP. You are going to give something like a sigh. If now and then you have this deep breath, what's the benefit to you, this deep breath? It will open the alveoli. So you are going to give him a sigh which it can open or to recruit the collapsed alveoli. There was also a difference. A meta-analysis showed that NIMV was more effective than CPAP in improving the extubation failure. Yani patients who are extubating from mechanical ventilation, is better to extubate to CPAP or to CPAP with rate or to nasal cannula. Before we said CPAP is better than cannula or room air. Now another study said that if you extubate to nasal IMV, it's better. But for which group of patients? If you have a 2 kilo patients you are extubating, you don't need to put him in IMV, and even maybe you go to room air, not CPAP. But if you have a small baby, and this is study done here, patients who are less than 1,250 grams, when they are extubated to CPAP with rate, which is an IMV, or extubated to CPAP, the success rate was 94% of patients. Those who are extubated only to CPAP, the success rate was only 61%, and the p-value was 0.05. So it was statistically significant. If you have a baby less than 1,251 grams to extubate to nasal IMV, then you can wean from NIMV to nasal CPAP. Could we use NIMV as a primary mode of treatment? And could we use NIMV instead of CPAP? There is no consensus in that. And one of the study showed that there was a benefit if you brought a patient less than 35 weeks on NIMV as a start, reduce the need for intubation and incidence of BPD. But not everybody is agreeing to start directly on IMV. Some people start patient on nasal CPAP, increase the PEEP 6, 7, and you feel that your patient is failing, and if you don't want to intubate him, and you think maybe he can do it on CPAP, you can just add a rate to the CPAP. But this study confirmed for patients less than 35 weeks, started on NIMV, we have less BPD and less intubation than CPAP. However, the conclusion was that further study is needed, but NIMV may be a promising non-invasive method of ventilation for preterm infant at risk of RDS. For the setting, how to put the patient on NIMV. NIMV is just simple. You put a CPAP, the same PEEP if you bought a PEEP of 6, PEEP of 5. Then you will add some rate. The rate will differ. If your patient has high CO2, you can see here they are bringing a big ring from 12 to 30. Patient with CO2 of 70, you need to increase the rate. Patient his CO2 is going down to 35, 40, you can drop the rate. The BIP and PEEP. The PEEP of 6, you can make it 5, 6, 7 depending on the inflation of your lung. The BIP from 14 to 22 depending on the excursion of the chest. Is it surging high or there is no chest rise with ventilation? The idea is to keep the saturation, FI2 to keep saturation between 88 to 92. And ventilator setting after extubation, it is nearly the same setting, but it's better to prolong the I time. We mention why I time, because this will behave like a sigh. This is going to recruit the collapsed alveoli. The use of CPAP in the delivery room. Do you have a new buff here in our unit? New buff. You don't have a new buff. Even now it is a recommendation in the new NRP. The new buff, this is something to, or TPs. One of them is called new buff. They have a PIP and they have a PEEP. You will adjust your machine. It's a small machine like a ventilator. You adjust the PIP, you adjust the PEEP. If you just close the valve, it gives you a PEEP 5, 6 as you need. And by closing it by your finger, this is going to give the PIP. So you apply the face mask again to the face, the same like the CPAP, but now you are giving to do a PIP. The difference between this one and the bag, if you are giving the pressure by your hand in the delivery room, patient is apneic and you start to give him bagging. One bag can give 20, another one can give 15, another one can give 25. So you are not giving a fixed pressure. But when you use this new buff, you adjust your setting before the start. So this now it is a recommendation in the delivery room to have the new buff, because now you are controlling the PIP and you are maintaining the PEEP. With the bag and mask, you give a pressure, you create a pressure, now you release, your PEEP can go down to 0. But this one you give a fixed pressure, PEEP of 5, PEEP of 6, to keep the lung well recruited, and you will give a well controlled pressure. This is to avoid the barotrauma. These are the European consensus guidelines. This guideline was came out in 2010 about the role of the CPAP on the treatment of RDS. So the recommendation of that any patient who are at risk of RDS to be started on CPAP, they recommend to start all baby from delivery room who are less than 30 weeks of gestation immediately on CPAP. Don't wait for the patient to deteriorate, to start grunting recessive. Recommending to start him directly from delivery room on CPAP, take him to the unit, and if it's okay you can wean him gradually from the CPAP until their clinical status can be assessed. The other recommendation is the use of, as we mentioned, short binasal bronch. We explained why before, because if the resistance is less, higher pressure will be transmitted and higher tidal volume generated, and maintaining the functional reservoir capacity better. Ventilation with a T-piece, which this is a new buff. Device is preferable to self-inflating back or flow-inflating back in order to generate appropriate PEEP. The use of CPAP with early rescue surfactant should be considered in baby with RDS in order to reduce the need of mechanical ventilation. This is the ensure technique. Intubate, give surfactant, and extubate. Intubation should be reserved for babies who have not responded to post-viral ventilation or who need CPAP. One of the recommendations is to give surfactant in this guideline to all babies less than 26 weeks. So they recommend any baby less than 26 weeks, intubate, give surfactant. If he is stable, consider early extubation. If you give surfactant, once your patient is stable, does not require any probe, his heart rate okay, blood pressure is maintained, try to extubate early. Because there was one of the observations, the longer you keep the patient on the ventilator, the more difficult to remove him from the ventilator. If you say no, he's small, I will wait for some time, he will gain weight, he will be better. No, it will be the opposite. If you keep him longer, it will be more difficult to extubate to CPAP. Okay, thank you. Any question?
Thank you, Ali. Thanks for the question, please.
معلش معلش ميكونيوم
ان هو في ارتلابي وفي كارت لاين.
يعني
ممكن نستخدم السجاد معاه. السجاد.
يعني
مش هيزود الارتلابي اكتر.
Yeah, it will, but you need to open the airway now, because the plugs, where is the plugs lying? The meconium plugs. If you have a ball valve mechanism, it can be in the airway. And you need to reopen the collapsed alveoli. How are you going to open? Sorry?
Other alveoli inflated.
Inflated, but what you will do? The other thing, either CPAP or ventilation. You start usually meconium aspiration. If patient is deteriorating, we start with CPAP to recruit the collapsed one to stent the upper airway. But you will give you don't give higher CPAP. You can start by CPAP of 5, for example, for the lung disease. You're not going to give CPAP of 8 if your lung is hyper inflated. If it is failed in the CPAP, you will shift to mechanical ventilation. Because sometimes patient on meconium, they can have other reasons, not only the lung. They have developed persistent pulmonary hypertension. They can have intrapulmonary shunting, hypoxic respiratory failure. It's not only the recruitment of the lung. Other causes can be.
You said that if patient stayed on FiO2 more than 30 minutes after, then you consider it failure. It
considered. Some people 0 to 60, but this nowadays, as you mentioned, if you more than 40, consider as a failure. If you want to give in and out surfactant, it's okay. Because the longer you wait, the study also have shown that more than 40%, you will have higher incidence of air leak syndrome.
Okay, another question, please. Do you recommend that after extubation, you put the patient on nasal CPAP?
Yeah.
Not less than 3 days?
No, not less than 3 days. I mean to think about extubation after, if you extubate a patient who is less than 1,250 grams to CPAP, it's better to think about removing from CPAP after 3 days.
Okay. If it's stable after 1 day, we can consider
mechanical ventilation is science and art. It's not a fixed guideline. I didn't say 3 days you should follow. If your some patient, you can extubate that. You said you can extubate to CPAP, you can extubate with a cannula. But CPAP, we have less rate of failure. You mentioned number to treat is 1 to 5. So if you are extubating 5 cases, you will prevent 1 case of failure. Science and art depend on your patients. No, not all are fixed protocols.
Different types of CPAP, public CPAP or ventilator CPAP?
Wallahi, some people about bubble CPAP, some think that in this bubbling it can work in a way like high frequency ventilation. But there was no a big difference. In our unit we are depending on ventilator CPAP. Some places depending on infant flow CPAP and the flow CPAP. Bubble CPAP, it's used by some because it's cheap and easy to be done if they cannot buy this expensive ready one. But to work as a high frequency, the bubble CPAP, they found no big difference. There was a thought that this bubbling can work as a high frequency affecting the chest. But there was no big difference in the different study.
Thank you, Dr. Ali.
العلم يحلو كلما كررته ولذاك عدت مكررا لحلاوته وبكثرة التكرار يكثر نفعه وبكثرة التكرار يكثر نفعه فادأب لي